Welcome to Lesson 9. This lesson is about managing common symptoms in late-stage Parkinson's disease. In the first part, we concentrate on symptom control. And in the second part, we discuss issues related to nutrition and hydration. In this lesson, you will learn important symptoms, which occur late in the course of Parkinson's disease, how to recognize, and to treat them. We will look at the symptoms of stiffness and rigidity, discuss delirium, with its particular form of hypoactive and terminal delirium, respiratory regulation disorders, especially Cheyne-Stokes breathing patterns, and vocal cord paralysis in MSA, dopaminergic crisis, specific emergencies, palliative sedation, and constipation. When stiffness and rigidity are increasing in the advanced phase, there is often a lack of fluids and medication intake. The main causes for an increase in stiffness are reduced fluid intake, problems with taking medication, and thus reduced medication levels, and constipation, with resulting poor absorption of the medication. The cause of these changes is swallowing difficulties. Treatment might be quite individually. At first, fluid substitution should be considered, and in difficult cases, a feeding tube placement. If this is considered, discussion about jejunal tube placement, and consecutive application of duodopa should be followed. This drug will also be available as a subcutaneous formula soon. Therefore, it might be considered at first, to place a nasogastric tube, which could be used for fluids and medication including duodopa. Furthermore, special medication might be needed, using various modes of application. Particularly nursing aspects, such as sufficient positioning of the patients to avoid decubiti, or also sufficient passive movement, to avoid contractures is important. A phenomenon called stiff person-like syndrome is observed in Parkinsonian patients in the late phase. This syndrome is characterized by stiffness that exceeds severe rigidity, and has little response to dopaminergic medication. Benzodiazepines are useful, for example, as lorazepam or midazolam, even as a continuous subcutaneous infusion. In the following slides, we will address the symptom of delirium, with a special focus on hypoactive delirium and terminal delirium. Already in an early woodblock print of Ars Moriendi, The Art of Dying, at the end of the 15th century, a man can be seen, who has significant weight loss, lying in the bed and misbehaving. That woodblock print shows that delirium at the end of life has been recognized already at the end of the Middle Ages. These are the two different explanations where the word delirium comes from. It is either from delirare, which means being mad, or from delira ire, which means going off the track. Delirium can be divided into different subtypes. The following lesson should concentrate on hypoactive and terminal delirium. It is well known that hypoactive delirium has the highest prevalence in hospital patients. And it is also very high in Parkinson's patients. Delirium has various clinical characteristics that should help to make the diagnosis. Clinical characteristics include altered perception, cognitive impairment, disorientation, gradual deterioration, and fluctuations. These fluctuations are characteristically for delirium, and it distinguishes between epileptic seizures or stroke, where also alterations of mind can take place. Often hallucinations are also part of delirium. These are misperceptions of the patient, that are not visible from the outside. There exist different useful assessments for delirium, for example, the CAM. A confusion assessment method instrument, or the New Day SC, Nursing Delirium Screening Scale, or DOS-S, Delirium Observation Screening Scale. The SQID, or the Single Question in Delirium, is the shortest diagnostic tool, but has a high sensitivity. Test it next time. Parkinson's patients are 5 times more likely to be treated for delirium. In a study with 46 patients treated for Parkinson's disease, in 24% the cause of hospital admission was confusion or delirium. There are some other predisposing factors for the occurrence of delirium. Deafness and blindness predispose to delirium, as does cognitive impairment, age over 65 years, various medications, such as some psychotropic and anticholinergic drugs, but polypharmacy is also a predisposing factor. Electrolyte disturbances, malnutrition and fluid deficiency, hypoxia, alcoholism, various comorbidities such as infectious diseases, multiple pre-existing conditions, especially chronic liver disease and kidney disease, strokes or other neurological diseases, bone fractures or trauma, terminal illnesses are important predisposing factors. Functional status with dependence or immobility, frailty, and recurrent falls, pain and constipation, little social contact, and sleep deprivation might be predisposing factors. There are some preventive measures to prevent the development of delirium. First of all, care should be taken to ensure sufficient fluid substitution and nutrition as well as adequate mobilization. Concerning medication, care must be taken that on the one hand it is sufficient, for example, in the treatment of pain, but on the other hand, the necessity of each medication must be checked for possible interactions and the correct dosage. Withdrawal symptoms, due to a possibly too rapid phasing out of substances, on which the patient is dependent, must be watched out for. Excessive sensory stimulation should be avoided. In addition, or as an alternative to medication, there are several non-drug measures in the treatment of delirium. Identifying predisposing factors means taking a history, especially asking about the occurrence of previous delirious or psychotic states, substance abuse, incompliance, and recent changes in delirogenic medication. Depending on the current situation, the detection and treatment of medical precipitators includes the clinical examination, if necessary, the determination of laboratory parameters, measurement of vital parameters, in individual cases possibly also supplementary diagnostic measures, such as an ECG, a chest X-ray, or possibly even a blood gas analysis. It makes sense to create an atmosphere that is as familiar as possible for the patient, in which well-known people are present and the environment remains familiar. For adapted communication, it is advisable to have a consistent caregiver, comforting and calming conversation, with the help of translators if needed. Avoid tube feeding if possible. Provide glasses and hearing aids. Correct and maintain sleep-wake cycle by making sure that during daytime bright light and mobilization is applied, and on the other hand, calmness and dimmed light at night. Soothing and calming measures can be provided in the form of music, massage and other relaxation techniques. Avoid distracting noises as TV etc. In selected patients, further examinations will be necessary, as EEG and lumbar puncture. Overall, it is of utmost importance to provide safe mobility with a minimum of restraints. This can be ensured by mobilization with therapists, nurses and relatives. Provide rollers and wheelchairs if appropriate. Use head and joint protectors. Low beds and cushioned floor can prevent serious injuries. Avoid bladder catheter and use sitters as needed. Hypoactive delirium in Parkinson's patients is quite common. Also, in patients with atypical Parkinsonism like PSP, or CPD, hypoactive delirium is more often than in idiopathic Parkinson's disease. However, common causes of hypoactive delirium like dehydration or hypoglycemia must be excluded or respected. Even subdural hematoma might contribute to hypoactive delirium. SDH often develop even after mild head trauma, and therefore anamnestic evaluation might be critical. Epileptic seizures, and status epilepticus, are frequent causes of hypoactive delirium in Parkinson's disease, and must be evaluated, using EEG analysis. Progressive dementia might contribute to hypoactive delirium as depression can cause it. The giving up syndrome might be a form of depression in Parkinson's patients, but frequently patients are not severely depressed when having this symptom. It comprises of frankly talks about the wish for hastened death. For the treatment of hypoactive delirium, first you might remove some of the causes, which have been mentioned earlier. Also, an increase in the dopaminergic drugs might alleviate symptoms of hyperactive delirium. If there are no hallucinations, and no restlessness, you can try amantadine IV. It even can be given SC in some patients, but caution must be taken, since sometimes it can result in skin trauma. Sometimes methylphenidate is recommended, but mostly, only for a short time. Most authors recommend only to use it for 5 days, and if there is no effect, to stop it again. There is a well-known fairy tale describing terminal delirium. The Little Match Girl. You might have been told this story as a child. The match girl is a poor girl who sells matches. It is Christmas time, and very cold, but she cannot sell any matches. So, she lights the matches by herself, and it enables her to look through walls into the houses where families celebrate Christmas. Finally, with the last match, she sees her grandmother, who always has loved her. The feeling finally is cozy and warm, and her grandmother takes her away. The next morning, the poor girl is found lying dead on the street. It is a very sad story, but it is a good example of a positive hallucination, which means that there are hallucinations, which might give a positive feeling in the moment we die. These hallucinations should not be cancelled and destroyed by the use of drugs. It is important to recognize terminal delirium, since there is a restrained use of pharmacological treatment. Drugs should only be used in case the patient suffers from delirium. This could be because of bad hallucinations or feeling in bad company. If possible, the inclusion of caregivers is important, which means that at best, they should stay in the same room, or even sleep in a bed next to the patient's bed. Physical contact can be one of the most important treatment options in this time. It provides support and helps the patient to feel at home. As discussed in Lesson 8, the home might be where the loved ones are. Patients with Parkinson's disease show fewer respiratory-related deaths, as compared to controls and PSP patients. Therefore, the breathing pattern might be very well preserved in these subjects, even at the end of life. Nevertheless, changes in the breathing pattern may occur. Due to the stiffness of the respiratory muscles, the breathing pattern may change. Dopaminergic drugs are recommended as a possible therapy. If the disorder is due to pneumonia, the use of an antibiotic must be considered. Epileptic seizures can also change the breathing pattern. Therapy for this would be anticonvulsive medication. Changes in the frontal brain area, or a subdural hematoma, can cause changes in the breathing pattern. In the case of a subdural hematoma, surgery should be considered. Some medications change the breathing pattern. In this case, the medication should be reviewed and evaluated for necessity. Intestinal problems can cause lymphedema, which can also alter the breathing pattern. Massages, or other laxative measures, can help. General measures that can always be used for dyspnea are: open windows, calm the patient, and find a suitable position for the patient. Even a small ventilator, put in front of the nose, might be helpful. Sometimes the cause of the dyspnea is a laryngospasm. Often it can be seen in patients with multiple system atrophy, but sometimes also in Parkinson's disease patients. In severe cases, a tracheostomy might be done, especially when the patient suffers a lot. In severe cases, the patient's ability to talk is significantly reduced, and therefore, tracheostomy does not all of a sudden takes away the communication. There might be severe cases at the end of life, and in these situations, palliative sedation can be helpful. Palliative sedation does not mean terminal sedation, and in this case is used to reduce the muscular spasms. Groaning means the symptom that patients make noises sometimes day and night, and they can't stop it. It is often part of a frontal lobe affection. Tracheotomy might even be effective in these cases, since patients in severe cases are not able to talk. In our experience, patients who are affected by pneumonia should immediately be treated. Untreated pneumonia can cause significant progress of the disease, and the patient might even lose power and weight. If severe pneumonia cannot be treated with antibiotics 3 times, it might be final pneumonia, since the body is too weak to fight against the infection. Palliative sedation can resolve fear and coughing and relaxes the body. Now we will look at the hypokinetic, or akinetic crises. Hypokinetic or akinetic crises might develop when patients are not able to swallow the medication, or in case the dopaminergic medication has been reduced too quickly. However, also vomiting and an ileus lead to a dopaminergic crisis. Especially vomiting can be a sign of ileus in Parkinson's patients, which might develop in the advanced phase of the disease. Patients are often not able to describe the abdominal pain associated with ileus, and therefore, it has to be excluded. Be careful at the end of life. When swallowing difficulties reduce dopamine intake, never simply stop dopaminergic treatment. There are possibilities for dopaminergic substitution, for example rotigotine patch. A malignant dopamine withdrawal syndrome might develop within 48 hours after a sudden stop of dopaminergic medication. Besides symptoms of a hypokinetic crisis, an increase in body temperature and also an elevation of creatine kinase can be observed. But even if there is a further dopaminergic treatment, severe stiffness can develop. It might be due to slow or missing absorption of levodopa or an application of dopamine agonists because of delirium or hallucinations. The clinical situation can be comparable to the stiff person syndrome, and even elevated levels of dopamine cannot alleviate the stiffness. In such cases, a benzodiazepine treatment can be successful, using drugs like lorazepam or even midazolam, for example nasal spray. The drug treatment in the advanced phase of the disease might be complicated. Often we cannot continue with drugs formerly used and therefore have to switch to other possible medication, since swallowing difficulties reduce the amount of medication possible. There have been experiences with the rotigotine patch and also apomorphine pumps. However, there are no clinical trials to describe an effect, since only limited data are available for the end-phase treatment. Duodopa might even be effective, but before this treatment, insertion of a feeding tube has to be done. As mentioned earlier, certain symptoms resemble stiff person-like syndrome, and do not respond well to levodopa treatment. In these cases benzodiazepines and even opioids can be used. Now, let us talk about obstipation, which is important not only in the advanced phase of the disease. We know that obstipation is common in Parkinson's disease, and that it appears very early on. In the advanced phase, some more causes for obstipation can develop, like hemorrhoids, anal fissures, or even a skin fungus. Therefore, an anal examination is important, since an ampoule filled with feces can often be observed when the patient complains of obstipation. It is always important to remind the patient and the relatives of fluid intake, since this influences the consistency of the feces. Obstipation might not be a problem in people with Parkinson's disease, but also the elderly population. Almost 1/3 of people over the age of 60 years complain about constipation. However, in Parkinson's patients, it is up to 80%. In the late stage of life, obstipation worsens, since there is less movement which contributes to less bowel movement. Furthermore, drugs induce obstipation like opioids, which should be carefully used in palliative care situations of patients with Parkinson's disease. Additionally, less fluid intake can be seen as a cause of constipation at the end of life. Obstipation can increase pain and even induce pain. Therefore, it is important to follow this symptom frequently. The pathophysiology of obstipation is reduced intestinal mobility at one hand, and on the other hand the transmural transport of fluids. Reduced mobility leads to an increase in the passage time. and the transmural transport of fluids leads to an increase in resorption, especially of fluids, which hardens the feces, and at the same time a decrease in secretion. As mentioned earlier, reduced frequent movements and reduced intake of food and fluids as well as a low-fiber diet lead to obstipation. Besides opioids, medications like anticholinergics and 5-HT3 antagonists decrease intestinal mobility. Obstipation can be treated. There are several pharmacological treatment options, including osmotic laxatives, stimulating laxatives as well as lubricants. Sometimes it is necessary to combine 2 or 3 different drugs, and in these cases, you might choose drugs from different groups, for example combining an osmotic laxative and a stimulating laxative. Additionally, an intestinal enema can be used early in the treatment regimen. Always helpful is a colon massage, which can also be used by relatives of the patient. It is an important nursing measure. Palliative sedation is an oft-ethical discussed term, and therefore, we will have some insight into the ethical and practical debate. In Lesson 7, you already learned about the 4 ethical principles: autonomy, beneficence, non-maleficence, and justice. These principles have to be the basis of all medical decisions. Since palliative sedation needs a frank ethical debate, we have to know these principles. An important part of end-of-life decisions is about withholding and withdrawing food and fluids as well as medication. These decisions always have to be made based on the patient's best interest, and written documents, like advanced directives, which were discussed in Lesson 7. Palliative sedation does not mean terminal sedation. A high symptom burden might make it necessary to use sedation, but with the option to relieve suffering and not to end someone's life. Palliative sedation depends on symptoms that justify sedation. The European Association of Palliative Care has not only provided guidelines for palliative sedation, but also a list of symptoms that should be considered for sedation. It is important to monitor sedation, which does not mean transferring the patient to an intermediate care unit, and connected the patient with a monitor, but to clinically evaluate the deepness of sedation and the symptom control associated. It is not always necessary to use deep sedation in the meaning that the patient is completely sleeping. Often mild sedation in a state where we still can communicate with the patient is sufficient. Palliative sedation is often used for dyspnea or pain. However, in recent years, pain treatment in Parkinson's patients has emerged, and I have not experienced the need for sedation for the last 10 years. More often palliative sedation is used for dyspnea, like the vocal cord paralysis in multiple system atrophy or severe stiffness in corticobasal degeneration. Only rarely do these symptoms occur in Parkinson's disease, but a stiff person likes syndrome in the advanced phase at a time, when the patient often is lying in the bed, or wheelchair-bound. Far more symptoms like agitation, or even delirium occur in Parkinson's patients, which might require sedation, since typical neuroleptics cannot frequently be used in these patients. However, benzodiazepines are also effective in Parkinson's delirium. Benzodiazepines like lorazepam or midazolam are also frequently used in palliative sedation. An important differential diagnosis of delirium in Parkinson's patients is epileptic seizures, or even a status epilepticus. Also in these cases, the first-line therapy with benzodiazepines can be used in palliative sedation, often treats a non-convulsive status epilepticus. It is important to know that palliative sedation does not shorten life, and as mentioned earlier, is not generally terminal sedation. Therefore, a considerable experience is necessary to use palliative sedation. As mentioned earlier, there are some specific symptoms of Parkinson's disease, which might require palliative sedation. Vocal cord paralysis is often associated with the acute onset of dyspnea in MSA patients. Some of these patients even have been tracheotomized to relieve dyspnea. However, dyspnea in vocal cord paralysis often becomes apparent with minor symptoms, long before a status of acute dyspnea occurs. The patient complains of reduced breathing capacity, or cannot finish a sentence, and has the feeling that breathing is shortened. In the acute phase of vocal cord paralysis, the use of benzodiazepines is strongly recommended, since this medication is also a muscle relaxant that alleviates symptoms of shortness of breath. Sometimes a status epilepticus occurs as a sign of massive neurodegeneration in the final days, especially in patients with progressive supranuclear palsy, but also in Parkinson's disease. Anticonvulsant therapy might not be able to effectively treat status epilepticus, but benzodiazepines reduce convulsions. Severe rigidity, and even spasticity, can be seen in the final days of Parkinsonian patients, and I might call this situation stiff Parkinson syndrome, since it is very close to the stiff person syndrome, and also can be treated with the use of benzodiazepines. In this case, palliative sedation has to be closely monitored, and as soon as possible an oral treatment with benzodiazepines should be considered. Also in severe aspiration pneumonia, palliative sedation is used, and in this case, might easily merge into terminal sedation. In the next chapter, we will summarize specific emergencies in the final phase of Parkinsonian disorders. The specific emergencies are status epilepticus and delirium. Both can have the same clinical presentation at the end of life in Parkinsonian patients. Furthermore, because of swallowing difficulties, acute choking, and laryngospasm, both associated with acute dyspnea, are serious emergencies. Also, aspiration pneumonia can lead to dyspnea. For the actions and treatment necessary to cope with all these emergencies, please see the chapters related to it. Pain is not a widely seen symptom in Parkinson's patients at the end of their lives, but even if it is a rare symptom, we should know the most important facts. Pain syndromes in Parkinson's patients can be divided into musculoskeletal, neuropathic, nociceptive, and central pain syndromes. Musculoskeletal pain can be subdivided into muscle cramps, which can occur in all extremities, but are frequently described in the legs, skin pressure, and even more often constipation. Very often, patients complain about constipation, and in the advanced phases, it has to be taken seriously, since it might indicate subileus leading to ileus. Some patients complain about neuropathic pain syndromes, which are comparable to painful diabetic neuropathy. A rare pain syndrome is the central pain syndrome, which might occur after stroke, but also in neurodegenerative diseases. Dystonia might cause pain, but often dystonia is surprisingly free of pain. This woman has severe dystonia, and suffers from CBD. The muscles and the joints are in unnatural positions. The patient in the picture has never complained about pain. However, at the end of her life, when she almost could not move anymore, she complained about pain. It is still unclear which mechanisms contribute to pain perception in Parkinsonian disorders. Several factors influence the pain threshold. Of course, well sleeping increases it, as well as the manner how the relatives deal with it. Understanding and empathy make it easier to tolerate the pain. This generally improves the mood, and as supporting drugs you can use antidepressants, and also anxiolytics, to treat anxiety and the fear that pain will come back all of a sudden when it is well treated. If possible, creative activity increases the pain threshold. On the other hand, all opposite of these factors decrease the pain threshold, for example, sleeplessness, increased anxiety, and depression, as well as social isolation and loneliness. Some of these symptoms can be effectively treated with appropriate medication. At the end stage, when patients are unable to communicate, one has to carefully observe the body language to interpret possible pain symptoms. Generally, pain should always be suspected in a person who has an abnormal body posture. However, there are even slight signals of pain, which also can be seen on patients awake or comatose. Most common might be a distorted body position, or lips pressed together. Furthermore, eyes shut and pressed together, and constant twitching of the ankles, of the mouth might indicate pain. Please also think of status epilepticus. If a Parkinson's patient shows one of these symptoms, since also in non-convulsive status epilepticus, the signs of myoclonic jerks can be very mildly. It is recommended to use pain scales, and in this situation the ZOPA, the Zurich Observation Pain Assessment, can be used. This slide supplements the previous one. It is important to recognize if a person in pain is protecting some body parts. This might indicate pain in this body part, or even another body part, which cannot be protected. Also, hitting and repelling the person who wants to touch the body or body parts is a typical reaction. Often the tension in the muscles is increased in pain, to avoid certain positions, or to alleviate the pain. Often seen in Parkinson's patients who suffer from pain, are changes in breathing patterns, and increased sweating. Breathing pattern changes might be used to cope with the pain, and can be dramatically not only showing an increased frequency of breathing, but also more deep breathing. Lacrimation without crying or weeping can be a sign of pain, especially in patients who are unable to talk. The use of opioids in Parkinson's patients is an ongoing debate, since some reports show worsening of Parkinsonian syndromes during opioid therapy. However, it depends on which opioids we use, and how to use them. We should not increase the dose in too short a time, so that the patients might be immobilized or even sedated. There might be some patients, in which opioid use reduces cognitive performance. This especially can be observed in short-term memory performances, and word-finding difficulties. Caution has to be taken, since opioids can increase the risk of falls, and therefore the frequency of falls should be carefully monitored during therapy. Rarely, excitatory reactions are seen. More often are complications with obstipation and subilius. In these cases, a change in opioids might alleviate the symptoms, but sometimes, it even will be the cause to stop opioid treatment. The non-pharmacological treatment options are important, and often already well respected by nurses. The best position in bed has to be found carefully, and this position even has to be changed frequently to avoid the pain, but also pressure ulcerations. It often is recommended to build a nest, so that the patient feels safe and comfortable. To find a comfortable position in a wheelchair can be challenging, but should be tried since a sitting position is important in some pain situations, and even gives the patient the impression of a natural position, while not constantly lying in bed. Lymph drainage and massage of the muscle is a well-accepted method for pain treatment. In these cases, massage of muscle, which are also in a distance from the painful body part, can support the treatment. Pain perception has several components. One important, but often neglected, is the spiritual component of pain. Pain in the advanced phase of the disease might goes along with fear of death, but also the question of guilt. What have I done that causes my suffering? Often the perception of body changes, in combination with pain, could be difficult. Several questions might arise in a painful situation, such as the questions about loneliness and the meaning of life, in such a situation. From that arises the question of what am I worth? Religious and even non-religious might inquire about God's plan. However, we still know too little about the spiritual dimensions of suffering in Parkinson patients. So far, there is too little information about spirituality in patients with neurologic diseases in general. Still, we have made an attempt to address this important care dimension in Lesson 11. Patients in the final stage of Parkinson's disease frequently suffer from pain. Compared to Parkinson's patients, PSP patients express far less pain. Pain has to be addressed, as it significantly reduces the quality of life. Always consider physiotherapy, additionally to medication. Be aware of opioid side effects, and treat those if needed. Most Parkinson's patients suffer from pain if they are lying in bed most of the time, or are in their final stage with reduced spontaneous movements. At the end of this lesson, which deals a lot with symptom control, we once again want to cite Dame Cicely Saunders, who has admonished healthcare providers as follows. We have to listen to the details of symptoms, giving constant attention to changing needs. We are concerned both to relieve suffering, and that our patients should maintain their character and style to the end.